Good morning. I'm here to present a comparative study between extended depth of focus intraocular lens, IDOF, and monofocal intraocular lens. Cataracts are the primary cause of preventable blindness in developing nations. Advancement in surgical techniques and IOL technology have transformed cataract surgery into a refractive procedure for visual rehabilitation. Over the past 5 decades, numerous lens types and designs have been developed. So monofocal IOLs have a fixed refractive power and a focal length. They ensure excellent distance equity. Patient requires spectacle for near and intermediate vision. Whereas extended depth of focus or IDOF IOL is a new technology that has recently emerged in the treatment of presbyopia correcting IOLs. These lenses work by creating a single elongated focal point to enhance range of vision or depth of focus. An ideal IDOF IOL provides a sharp focus over a wide range, giving patient excellent distance and intermediate vision. These lenses aim towards decreasing the side effects like aberration, glare, and halos. So my aim is to comparative analysis between IDOF IOL and monofocal IOL in patients undergoing cataract surgery. And my objectives were to evaluate the postoperative outcomes including distance, intermediate, and near visual acuity, to compare the incidence of dysphotopsia, to assess overall patient satisfaction with regard to driving difficulties and dependence on spectacles following surgeries. It's a prospective case control study in patients undergoing phacoemulsification with IOL implantation, monofocal and IDOF IOL, in a tertiary eye care center in Kerala with a study duration of 9 months, and 51 eyes were selected. All the patients with age-related cataract above the age of 40 years were enrolled, excluding whom with a previous ocular trauma, coexistent ocular pathologies, any macular pathologies, eyes with maximal pupillary dilatation less than or equal to 5 mm, and patient with astigmatism more than or equal to 1 diopter. Now, patients undergoing cataract surgery were provided a choice for choosing types of IOL to be implanted after discussing the pros and cons. Now, preoperatively, their distance visual acuity was tested with a ETDRS chart. Now, near vision were tested using Snellen's chart. Then Goldman's applanation tonometry were used to IOP measurement. And with IOL Master 700 and Barrett's formula, IOL power was calculated. Then postoperatively, at the first and third month follow-up, distant and near vision were tested. Intermediate visual acuity were tested with a precision vision intermediate visual acuity chart at 66 centimeter. At third month follow-up, they were also asked for glare and halos, and also asked regarding driving difficulties and spectacle dependence for daily activities. Now, total of 51 eyes were selected, out of which 13 were put for IDOF and 13 with a monofocal, among which my study primarily reflect outcomes in population over 60 years. So majority, 43% comes in the age of 61 to 70 years. Eyes were comparable with respect to all parameters, including the IOP, biometry, and visual acuity. Now, coming to the study result, at first and third month follow-up, there were a significant increase in the uncorrected near visual acuity and intermediate visual acuity in IDOF compared to monofocal, but the uncorrected distant visual acuity and best corrected near visual acuity was comparatively similar in both lenses. Also, IDOF lenses were associated with fewer visual disturbance, showing lower rates of halos and glare, while both lens types caused minimal driving difficulty. Also, coming to spectacle dependence, even though both the IOLs do not provide spectacle dependence, IDOF people will get a reduced need of spectacle, but it was not statistically significant. Now, if you come to discussion, monofocal lens shows slightly better early uncorrected visual acuity, but at the end of the third month, both IOL provide equal uncorrected visual acuity. Also, in near vision, IDOF lens shows significantly better uncorrected near vision. Intermediate vision was improvement with IDOF lenses, which is aligned with the references, but the previous studies reported halos and glares with IDOF, which was contrary to my study, which showed fewer visual disturbance. My study limitation includes small sample size, short follow-up period, subjective reporting, and potential variability. So on concluding, IDOF lens provide better intermediate and near visual acuity than monofocal, associated with fewer visual disturbance and lower spectacle dependence. Both lens types show excellent surgical and optical performance. IDOF lenses are ideal for patients seeking greater independence from reading glass. These are my recommendations. A large sample size could have been needed with longer follow-up periods, objective assessment tools for evaluating visual disturbance more accurately. Thank you.
do this comparative kind of a study, the n size on either side should be same. It cannot be 13 and 50. It cannot. Then all data will be skewed. You cannot have any relevant data. Point number one. Point number two, all other factors you should equalize. Same surgeon, same type of cataracts, like that you should you should make it clear, like same machine, all that. And third is, I was interested as you are telling us about these findings. I was interested whether how many patients, if they are going to stay without good correction for 3 months, as you said, I think that will be a torture on the surgeon. The other eye also, that fellow will not get operated. So what will you do? So that will become, in my opinion, the ultimate bad thing about EDOF. You are projecting as if a person gets EDOF, you'll have to wait for 3 months before you even advise him other eye surgery. That's what I think you're showing. So that is, I think, an over-exaggeration. It's not that very true. So go see your data again, and there is something wrong there in that statement. It is not correct. And this intermediate vision chart, which you are using, how much value addition it was giving? Were you doing or an optometrist was doing?
I was inquiring. They were doing.
So in that, was it reproducible? Were the patient happy with that? That intermediate vision chart, the precision vision chart?
Yes. The thing is that with monofocal they could not read that much line, but with EDOF they could read much
better. Read better. And your sample is always above 60. So we presume that most are at home. So that way you had an easy group with you. This is an easy group, so that way. So do these modifications to the study and work it on a bigger n size.
The only thing is, whatever differences, they are well established. We know the plus and minus of monofocal and that of an EDOF. What have been compared is a monofocal, for distance, while driving and everything, was there any advantage with EDOF and then compared to monofocal lens? That would have been a better thing. And even with EDOF, for finer prints, they do need glasses eventually. Like, it's not a foolproof thing at all. Okay, so next time to compare without, for distance without glasses, what is the quality of, was there any significant difference in the quality of vision for either?